Intra-abdominal pressure hasn't traditionally had the attention it deserves. Why is that, and why is monitoring IAP so important?
I think that the reason why it doesn't get the attention is because of still a general lack of clinical awareness. Many doctors, anesthetists, surgeons are not aware of the issues related to increased intra-abdominal pressure, hence they do not measure. So I think there is still a lot of work to do regarding education and increasing this general awareness. On the contrary of the perception of many doctors who believe that intra-abdominal pressure is not important, I think it's extremely important. The abdominal compartment is at the center of our body, and when this pressure increases, it may have an impact on all organ functions, not only within the abdominal compartment, but also on the heart, the lungs, and the brain.
What are the physiological effects of an increase in intra-abdominal pressure?
Because the abdomen is really the center of our body, and the abdominal compartment can be considered as primarily fluid in character. Hence it follows the law of Pascal, which means that whenever the pressure is increased, it will be equally transmitted within this compartment. So I'm an internist of training, so I found it really fascinating because it has an impact on all organ functions.
And what are the risk factors for developing intra-abdominal hypertension and abdominal compartment syndrome? In which of them should monitoring be indisputable?
So with the Abdominal Compartment Society, formerly it was known as the World Society of the Abdominal Compartment Syndrome, but because nowadays we more and more focus on prevention, so we want to take away the attention from the compartment syndrome per se and focus on the abdominal compartment as a whole. So the risk factors can be divided into 4 categories. So the first would be any condition that causes a decrease in the compliance of the abdominal wall, which might be burns with circular burn wounds as scars, might be fluid overload, might be obesity. Second would be any condition that increases free abdominal fluid, as seen with ascites, with collections, with blood in the abdomen, also during insufflation and laparoscopy, you have CO2 gas. The third risk factor is any condition that increases the intraluminal content, which could be fluid in the stomach, distended bowels with stool, and so on. The fourth risk factor is mainly iatrogenic and anything which is related to massive fluid overload in the setting of a patient with sepsis and capillary leak, and in the combination with acidosis, hypothermia, coagulopathy, which has been referred to as the deadly triad. So you give more fluids, you get dilutional coagulopathy, more bleeding, and you have a kind of a vicious cycle. Next to these risk factors, of course, there are very well-known surgical risk factors. So if you have a ruptured aortic aneurysm, if you have a trauma with a liver or a spleen rupture, if you have a perforated viscus with a fecal peritonitis. So all these are very well identified risk factors, amongst others like severe acute pancreatitis, burn patients. So I think it's important to identify this risk factor, to screen the patient for the risk factor.
What method for measuring intra-abdominal pressure you think is the gold standard in intensive care?
So the gold standard is what the society has stated in a definition regarding the gold standard for abdominal pressure measurement, is the estimate via the bladder. So the bladder can be used as a passive membrane to transmit the pressure from the abdomen into the bladder and then outside the patient. So we do this with the patient in the supine position, making sure that there are no abdominal muscle contractions. We instill a maximum amount of 20-25 mL into the bladder, and we zero at the level of the mid-axillary line where it crosses the iliac crest. So this by definition is the gold standard of abdominal pressure estimation via the bladder.
How is intra-abdominal hypertension treated?
Intra-abdominal hypertension is a continuum. So you start maybe with a normal pressure, is around 5 to 7 millimeters of mercury. Hypertension is defined as a pressure of 12 millimeters of mercury and above. And then you have different gradings, 15, 20, 25 millimeters of mercury. So compartment syndrome is defined as a pressure of 20 plus new onset organ failure. And that's an all or nothing phenomenon. So either you have a compartment syndrome or you don't. So the main goal is prevention. So when you measure intra-abdominal pressure sequentially and you see that it's gradually increasing, that's when we start acting by medical measurements, so not surgical ones, by medical measurements to improve the intra-abdominal pressure.
IAP trend often appear to be regarded as unequally important by intensivists and surgeons. Who's right?
I don't think someone is right or wrong. I think it reflects to the difference in how they perceive the importance of abdominal pressure. I think many ICU doctors do monitor it on a daily basis so that you can have a trend. If I look at my personal experience, I've worked now in 3 hospitals. On average, it takes about 5 years. 5 years to get the concept of abdominal pressure into the daily treatment of your ICU patients. So you need to get the nurses involved because they will do the measurements. You need to get the ICU team convinced of the importance. And then, of course, you need to get the surgical team involved.